Good morning and welcome to this parallel session being hosted by Emergency Medicine. My name is Fergal Hickey. I'm a consultant in emergency medicine in Sligo, and I'm currently president of the Irish Association for Emergency Medicine. And it is IEM that's hosting this parallel session. By way of introduction, I have a few brief slides to show just to set some context on what we're going to talk about. I think all of us are aware that the resuscitation room can be a very difficult environment. It can be an alien environment for many people. And we know that there are many doctors who are particularly good at individual technical skills and seeing individual patients, but find the experience of being in the resus room and managing a team to be particularly challenging. So we're going to talk about that and some of the issues associated with it. So the objectives of this session, and the session is generally titled Leadership in the Resuscitation Room, is to try and focus on the human factor issues at play in a resus room. We're not going to concentrate particularly on the technical skills. A lot of what we're going to discuss is what's often referred to as non-technical skills. Just by way of a sidebar, the most significant air crash of all times took place on the 27th of March 1977, and I would suggest to you that it is well worth Googling this and even looking at the Wikipedia entry for it. This was a collision between two Boeing 747s, which produced 593 fatalities, which is the greatest number of fatalities ever. And there was a series of things which happened which precipitated. First of all, the main airport was closed because of a terrorist incident. So the pilots and crew were very unfamiliar with the Tenerife airport that they ended up being diverted to. There were lots of technical issues. There was a single runaway. And because there were so many planes had to be accommodated, many of those were accommodated on taxiways, which meant that they were blocked. There was significant miscommunication between the control tower and the crews. And a lot of this revolved around language, that the crew wasn't used to dealing with so many planes and call signs of that complexity. And much of their communication was open to misinterpretation. But more significantly, the fundamental failing was that the captain of the KLM 747 flight took off essentially before he had permission to do so. And the other members of the cockpit crew understood that he hadn't been given permission, but were afraid to speak up. And the report on this is well worth reading because it reveals many of the human factors issues, which are akin to what we see in emergency. So to structure this session, I'm going to do the brief introduction, as I've said, and then Mark Doyle will give a presentation on the general principles of the human factors at play in the resuscitation room context. We're then going to show you two scenarios, one adult and one pediatric, and there are predetermined intermissions in these where Emily O'Connor and Mark Doyle and that have been displayed. So the first one is how to step up in the resuscitation room, which will be Karen Harris and Vicky Meegans. And the second will be pediatric resuscitation, how to make the difficult decisions, which Laura Melody has been responsible for. But as I said, each will have an intermission to discuss the issues portrayed in the scenario. Now, what we want you to do is to concentrate on the leadership issues and the interactions rather than the technical skills demonstrated. So we're not interested in the intubation as such, we're interested in the decision making around it and how that's communicated. There is an opportunity for questions using the question function in the on-air platform, which on the right-hand side of the screen, as you're looking at it, there's an opportunity to ask questions. I'll moderate these and give Mark, Emily, and potentially one of the three people involved in the scenarios the opportunity to answer those at an appropriate time. And then at the end, the brief wrap up from me. So we're all living and experiencing COVID, and that has had an impact on what we're trying to do today. So we have been in the position to only have a limited number of personnel allowed into the resuscitation room. It has produced even greater difficulty in clear communication as a result of people having to wear masks and visors. And this is very evident in the videos. So in spite of sound enhancement technology being deployed, audibility is a challenge. And you'll appreciate, if you've been in a resus room during the COVID pandemic, how much of a real world issue that is. So I suppose for us, this is the real world. Our first speaker is Mr. Mark Doyle. Mark retired relatively recently as a consultant in emergency medicine in University Hospital Waterford. He has a particular interest in human factors and has an MSc in human factors. He's also my predecessor, one of my predecessors as president of the Irish Association for Emergency Medicine. So I'm going to hand over to Mark. I'm going to stop sharing the screen, and the next voice you'll hear will be Mark Doyle's.
Welcome to this virtual presentation on the human factors aspects of teamwork in resuscitation. I'm going to just talk about the background of teamwork and patient safety and give a brief review of the issues around the non-technical skills for teamwork. Human factors science is involved with designing systems resilient to unanticipated events and also to mitigating any harm that may occur if those events actually happen. It does this with the needs, capabilities, and limitations of people in mind, the people who have to work within these systems. Since the publication of the seminal work To Err is Human by the Institute of Medicine in the US back about 20 years ago now, there has been a huge amount of research and publication on patient safety in healthcare. All of this work highlights the importance of interdisciplinary teamwork as an important theme in patient safety. Let us remind ourselves of what happens when teamwork breaks down. Many of you will have seen this video before. I feel it merits repetition and should be compulsory viewing for resuscitation team members.
This is the story of the death of my wife, Elaine, who died in March 2005 as a result of an attempted routine operation that went wrong.
Elaine actually had very good health, but she had suffered from some sinus problems, and as a result, a consultant had recommended that she should have routine sinus surgery. She died some 13 days after the original attempted operation.
And at 8:35 in the morning, Elaine was anaesthetised.
Off we go now. Off to sleep.
The first mask wouldn't fit. They tried a second mask.
Why am I having problems here? Hold down a bit. Let me push the head back a bit more.
They then tried some extra drugs to try and reduce some suspected tension in the muscles in the jaw. So it was obvious almost straight away that things were going wrong. We know that 2 minutes in, Elaine's oxygenation was 75% and falling, and she was by this time already visibly blue. Within 4 minutes, we know that her oxygenation had fallen to 40% or lower. There's some confusion about the precise time, but we know that 6 to 8 minutes in, a number of things were happening. The anaesthetist had already started to attempt to intubate Elaine. The oxygenation was still at 40% or lower. The heart rate was falling. The ENT surgeon waiting to perform the op came into the theatre. An anaesthetist from an adjoining theatre became aware of a commotion, and he walked in to see what could be done. And at least 3 nurses answered a call for help. And what happened is that the 3 consultants continued with the attempts to intubate, and they used a variety of different techniques and a variety of different pieces of equipment. With hindsight, this is a situation of can't intubate, can't ventilate. This is a recognised emergency in anaesthesia for which guidelines exist. What we know actually happened is this point in 10 minutes for a further 15 minutes, The three consultants would appear to have continued with their attempts to intubate, and finally, by the time we're 35 minutes in, they seem to make the decision that the best thing is just to let her wake up naturally.
Let's wheel her back, quick as we can.
The lead anaesthetist, if I can call him that, in his own words, lost control. There was a question mark in the inquest about who people felt was in charge at different points. There was certainly a breakdown in the decision-making processes, and it would appear that the communication processes dried up amongst the consultants. The story with the nurses is very different. The nurses were generally aware of what was happening and what needed to happen. One of them asked her colleague to go and fetch the tracheostomy set. She collected the tracheostomy set, she came back in, she announced to the consultants that the tracheostomy set was available, and there was no response. One of the other nurses who walked in immediately saw Elaine's colour, immediately saw the vital signs, and walked out again to phone intensive care. She came back in and she announced to the three consultants that a bed was available in intensive care. And in her own words, they looked at her as if to say, "What's wrong? You're overreacting." She actually walked out and cancelled that bed. At the inquest, two of the four nurses stated that they knew exactly what needed to happen, but again, to quote from the inquest, didn't know how to broach the subject. We have a breakdown of leadership, of situational awareness, of prioritisation, of decision-making, of communication, and of assertiveness. And these same factors, these same human factors, ironically, are present in 75% of aviation accidents. And really, since then, I've been trying to understand why in aviation we train and to understand about human factors, and it's an integral part of how we design equipment and how we manage procedures and how we work day to day. It's part of our everyday language. But I'm trying to understand why that's not part of clinical practice. Human factors tells us that actually we're all wrong no matter how good we are, and we need people around us to help us. It's creating that open environment within your colleagues, being open to suggestions. If they put their hand up and say, "Excuse me, I'm not sure about this," it's not turning around and saying, "Actually, I'm the boss here." It's turning around and saying, "Tell me what your concern is." It's listening. This is the story. This is the story.
So bearing in mind the points raised in that video, let's talk about some of the issues. So initially, what is a team comprised of? And this is a definition from the American Agency for Healthcare Research and Quality, who produce a training program called Team Steps for healthcare team members. So I've highlighted a few words: interdependently, which means that the team members have to depend on one another, and specific roles. They do have to have a specific role in the team. Usually the teams are time limited, particularly action teams. Many of you will be familiar with Dr. Gowande, who's an American author and surgeon, who gave an interesting twist on the idea of teamwork. He stated that the traditional hospital consultant, he compared him to a cowboy, not the Irish cowboy, which means a chancer, but the American cowboy, renowned for rugged individualism, daring, independence, and self-sufficiency. But that traditional model is no longer appropriate for modern healthcare, and a more appropriate analogy is that of the Formula One pit crew.
But Holland comes in for a pit stop. Time to refuel and change tires. Lou Moore himself changes the tires. Only 4 crew members, including the driver, are allowed to work on the car. It's a tense time. Holland stays in his seat, anxious to get away. Let's watch. The tires are changed at last. A crewman polishes the windshield as Holland moves away just 67 seconds after he stopped.
So what are the unique characteristics of the emergency situation that might have impact on team working? Well, this list is fairly familiar to all of you, I'm sure. Problems can be ill-defined and ill-structured to start with, particularly. There's incomplete information in a rapidly changing situation with multiple conflicting goals under intense time pressure with high consequences for error. And in addition, the teams that gather for a number of resuscitation situations such as cardiac arrest are often not permanent members of that team. They come from different home teams, so to speak, to form an action team. So these team members have to bring the skills and awareness with them because they'll be working outside their home team. So what are these skills, these non-technical skills? So here's a definition. And I think the important point there is where it says that they complement the technical skills. Non-technical skills are not a freestanding element on their own. It's their impact on the technical aspects of care that actually matter. CRM stands for Crew Resource Management, which is the other name for this, which was used by the airline industry, which initiated this process. Divides into 2 groups, cognitive skills and interpersonal. The cognitive skills are situation awareness and decision making. These are dependent on working memory, which is limited and therefore susceptible to failure. The interpersonal skills are leadership, communication, and team working. Situation awareness comprises 3 elements: knowing what's happening, being able to draw a conclusion from what's happening, and then to anticipate what will happen depending on what actions are not taken. As I said, it depends on working memory and is in order to maintain situation awareness, it's important that the situation is continuously monitored for new information, new decisions that are made. And the purpose of the situation awareness is to create a shared mental model between all members of the team. A shared mental model is basically everyone being on the same page. It helps to create mutual understanding of what the situation is. This will lead to better communication and enable people to understand each other's roles, anticipate their needs, and back one another up to a common goal. Looking at these pictures, some of you may see a rabbit, some may see a duck, some may see an old woman, some may see a young woman. What matters is that the difference is communicated, that it's called out so that everybody is working on the same thing, and we don't have a situation where half the team are working on a duck and half are working on a rabbit. Decision making comes in two main types in emergency situations. There's recognition prime decision making, which is intuitive, going with your gut. It's fast, uses mental shortcuts, and usually results in a satisfactory solution. However, it can only be really effectively practiced by experienced people, and there are risks in relation to bias. The other type of decision making in an emergency is rule-based decision making. An example of that would be ATLS or ACLS protocols. It's good for less experienced team members. It's fast if the rule is learned off by heart. And it's decided by experts. Then looking at the behavioral skills that are required, we talk about leadership. There's a lot of debate about and writing about how leadership occurs, how leaders arise. There's also a lot of information around different styles of leadership. However, in our context, the leader needs to be primarily a communicator, but also they need to have a plan, a goal, and be able to set standards, assign tasks, and really bring the team together, encouraging support and information sharing. Communication is a problem and recognized as such. When it goes wrong, we've had incidents and reports such as these that you'll be familiar with, and it's commonly stated that communication failure is a prime cause of adverse events. Communication between healthcare professionals and patients is of paramount importance. However, the communication between healthcare professionals is also supremely important for patient safety. Communication is not just a one-way traffic. It's a complex interaction between the various people involved. While the spoken word is an obvious element, it's not the only one, and in fact, in some situations, is not the most important. Tone of voice, body language are equally and sometimes more important. This is a problem in the resuscitation situation because of PPE, background noise, and other distractions. The other barriers can be language, personalities, conflict, and workload. To try and overcome some of these difficulties, we have communication strategies such as closed-loop communication or feedback, using ISPAR 3, for instance, for handovers, calling out dangerous situations. And communication in an emergency needs to be brief, clear, timely, and complete. Finally, we've got teamwork or mutual support, where assistance is sought and offered among team members to reduce error. And it includes being assertive. And we saw in the Bromiley video what lack of assertiveness can do. But assertiveness is not aggressiveness, but equally it's not passivity. It can be learned, but it also is dependent on the culture in the team or institution that supports assertiveness. Assertiveness can start, usually it should be an escalating situation, starting with lower level actions, and then, but ultimately, team members being in position and having the authority to call a stop to things that they see happening that are dangerous or wrong. So to summarize, I'll give you these 6 characteristics of effective healthcare teams from this particular article. And in a few moments, we will look at one of our resuscitation simulations and discuss the issues that arise during that. Thank you.
Okay, thanks, Mark. So the way this will work is that we have 2 simulations which you're going to see, starting with an adult simulation. There'll be breaks in that. It takes a few minutes just to launch the actual video. There'll be breaks in it, and at that point, Emily O'Connor is consultant in emergency medicine in Connolly Hospital in Blanchardstown, and Mark will discuss the issues that arise. Can I remind you that there is a question function on the on-air platform that you're welcome to use, and we can put questions as they arise that are relevant to a particular point in the scenario to the 2 presenters. So we're going to move on now to the scenario.
Hi guys, so we have 55-year-old male en route with 3 episodes of hematemesis. He has a background history of liver disease and alcohol dependency, and he also has known esophageal RCs. And he has COPD and IHD. His respiratory rate of 20, oxygen saturation is 96, and 15 litres of oxygen. And he has a heart rate of 95. His blood pressure is 100/60. His GCS is 30, blood sugars are 4.2. Temperature is 36.5, ETA is 5 minutes, and pre-hospital are requesting recess.
Okay, thanks, Anna. Okay, I'm Karen. I'm the emergency medicine consultant on call. I'll be the team leader for this resuscitation. So it's a 55-year-old male with known varices and 3 episodes of hematemesis with a blood pressure of 100/60 and a heart rate of 95. So I suppose we have to be concerned about a variceal bleed here with developing hemorrhagic shock. So we take a ABC approach to the resuscitation. If he's stable, we need to do restrictive transfusion given his portal hypertension, but if he's unstable, we'll have to activate the massive transfusion protocol. He is actively vomiting blood, so we need everyone in full PPE, including visors. Okay, let's allocate roles. Callum, can you be the airway doctor, please? He is self-ventilating, but we'll need just oxygenation in the context of hemorrhagic shock. And can you take a history when he arrives as well, please? Yes. Colin, can you do a quick chest and abdominal assessment? Let me know of any positive findings, especially tenderness. And then can I ask you to be the circulation doctor? So we need 2 large bore IV cannulae, full set of bloods, including a cross match, and a fibrinogen level, please. And can we get an urgent VBG? I'll get you to communicate with the blood bank in the case where we need a massive transfusion protocol. So if you don't mind getting the checklist ready and pre-alerting the blood bank, please. We'll try and get a fibrinogen back early on this guy as well, please. Right. Emma, can you apply the monitors, please? And I'm going to ask you to prepare some drugs. We're going to need early antibiotics in this man, so could you prepare 1 gram of ceftriaxone, please? And will you make sure we have 2 units of O negative in the department, please? We might also need calcium, so could you get 5 millimoles of calcium ready, please? Okay, thanks. And if you get your PPE on, we'll rehearse our roles. Callum, do you just mind telling me from an airway point of view, what's your plan?
So I'm going to assess his airway when he arrives and decide on the level of intervention required.
Okay.
And then I'm going to take a history from him and prepare for RSI.
Great, okay, thanks. Colin?
Great, yeah, so I'll be breathing in circulation. I'll establish a large bore IV. I'll take off bloods, take off a VBG, group and cross match. I'll get in contact with the blood bank for massive transfusion protocol, and I'll do an ultrasound to look at his aorta and assess for ascites.
I'm the resus nurse. I'm going to apply the monitors when the patient comes in. I'm going to prepare the drug, and I'm going to do 2 units of O blood ready. Right. And I'll assist on with early.
Okay. We should also pre-alert the surgical registrar. Would you mind doing that, please?
Yeah, sure.
Is there anything else I haven't thought of?
Should we let the ICU team know?
Yeah, good idea, Colin. And Colin, maybe you get an ultrasound machine. We can have a quick look at his aorta and look for ascites. Emma, could you also let interventional radiology know, please? Thank you.
Hello. So Mark and I are just going to have a chat about some of the great human factors we saw in that start to this resuscitation scenario. So Mark, this is really text good behavior. We can see Karen using that pre-alert and that to do a pre-briefing for the receiving team. So the radio call has come in using the ASHISH mnemonic, so they know the patient's age, sex, the history, the illnesses, the condition of the patient, and the estimated arrival time. Karen uses, I suppose you could apply the step-up mnemonic, so she's kind of preparing herself and mentally rehearsing what she's going to do and what the members of her team are going to do. She's allocating roles and checking out the competencies of all the team members. And I really like the labeling that's done, particularly with PPE on. It's hard to identify people. She's checking out the environment, making sure they have all the equipment they need. And the plan for the patient is a CABC approach. And then she's continuously updating people's understanding and asking for any suggestions. So that was really impressive pre-brief. What do you think?
Yes, I'd agree, Emily. Actually, she's taking the non-technical skills from the start. There's an establishment of leadership straight away. There's no doubt about who's in charge. There's the beginnings of creating a shared mental model among the team, which obviously has to be watched depending on what actually happens when the patient arrives. I loved she's setting the standard of care. So she mentions CABC, that's how we're going to do this. She has great respect for her team members. She uses proper respectful language like thank you and good idea, etc., to build up the team's confidence. Yeah, there are so many good points to that. I mean, it's shown that pre-briefing can, there's evidence that it reduces mortality in surgical patients. It reduces time to critical interventions. So really worthwhile doing.
Yeah, and I think everybody, it's a very exciting time for emergency medicine to be waiting to receive a patient, but it's great that I think everyone in that resuscitation room is going to feel comfortable and safe in that period of waiting. So shall we go on and see the casualty arrive?
Yes.
Thanks, Adina.
Oh, who's team lead? Who's taking the...
Karen, I'm the team leader.
Right, my name is Colin, I'm the lead paramedic. So he's John Jones, he's a 55-year-old male. He's had 3 episodes of hematemesis earlier. He had 2 more en route. Patient has a history of alcohol dependency, liver disease, and esophageal varices. Pulse is 95, blood pressure is now 95/60. It's dropped, respiration 20. We have him on oxygen and non-rebreather nasal cannula is 96%. GCS is 13, which is a 3, 4, and 6. His UGL is 4.2, and his temperature is 36.6. He's zinc engaged in left AC. We haven't used anything. So allergies none. He's on Symbicort, salbutamol, and propanol. Background history of COPD and ischemic heart disease. No stents. And he's had 2 litres of vodka over the weekend. He's been drinking.
Okay, thanks, Owen.
Yeah.
Do you mind getting them registered, please? Thanks very much. Team, can we start our assessment, please?
Hi everyone, my name's Callum, I'm one of the emergency doctors. It's going to be a lot of things happening. You're in safe hands, okay? What's been happening to you today?
Just get sick. Oh, it's terrible. I feel sick.
Okay, we'll get you something for that. Do you have any medical issues?
Yeah. There are problems with COPD.
Okay, any problems with your heart?
I had a heart attack 2 years ago, and I've also got a PET-C.
Okay, are you on any regular medications?
Yeah, one inhalers, and also propanol.
Okay, do you have any allergies?
No. Sick.
Okay, when did you last eat?
Oh, last night. I'll see you doctor.
Okay, so Karen's airway is patent and protected at the moment.
Sick.
He's saying he's feeling nauseous.
Oh, thanks.
Karen, this curfew is midline and there's people bilateral.
I see a sample max 2 on the 15 litres there. Respiratory rate 23.
Okay, you want to see that?
Okay, it's not significant. Wow, okay. The large hematomas there.
And now here's the DBG.
Okay, I'll get them to do that.
Okay, so you've got IV access.
Thank you.
I have two large bore IVs. DBG has been taken and sent.
Right.
The group of hold has been taken and sent. Hematology bloods,
Yeah.
including a fibrinogen.
Okay, great. That's great, thank you. Okay, is abdomen tender?
Yes, we send her in the epigastrum.
Okay. Emma, can we go ahead and give the 1 gram of Ceftriaxone,
Yes,
please?
sure.
Okay, if you don't mind having a look at this. Okay, so we might just have a look at the ultrasound when you're ready there, Colin.
Hi, my name's Colin. I got direct base of the
Okay, so DBG is fast, pH is 7.1, P2 is 4, basic says minus 10, lactate 5.5, and hemoglobin is only 5.2. So it's hemodynamically unstable, a heart rate of 120 and a blood pressure of 80 on 60 there. Can you hand the 2 units of O negative, please, Anna?
I'll put it through blood pressure.
Great, thank you. Okay, thank you. Colin, what's the CCS now?
Can you answer me? You need to cut your tongue. So it's B3, M4, so GCS is 10, it's dropped.
Okay.
And I'm concerned that there's a lot of soiling in the airway.
Okay. Can you tell me what to see on ultrasound, Colin?
His abdominal aorta measures 2.5 centimeters in maximal diameter, and there is ascites in the right upper quadrant.
Emma, do you mind drawing up 2 milligrams of peripressin, please? And 250 milligrams of erythromycin as well,
Okay,
please.
no problem.
Hi, guys.
Hi, Karen. I'm Alan. I'm surgical nurse. I just completed my sorry.
That's okay. Thanks for coming down, Alan.
I'm passionate about you.
Hi, Pat. Thanks for coming down. Let's pass. Colin's worried about the airway at this time. We might just summarise the case and I'll let you take over airway then. He's a 55-year-old man with no liver disease and varices, and he's been having hematemesis this morning. He is hepatitis C positive, so important that everyone's got full and appropriate PPE on. His airway is patent but not protected. His breathing rests are 26 and SATs are about 88% now on the 15 litres. He's got a metabolic acidosis, pH 7.1 with a basic test of minus 10 and a lactate of 5.5. His hemoglobin is only 5.2 on his gas. He's tachycardic at 130, blood pressure is 85 on 60 now. We're just have 2 large bore IV access in. We're just starting 2 units of ONEG, and Colin has spoken to the lab and activated the major transfusion protocol. So I think he's hemorrhagic shock, secondary to variceal bleed. I think his airway is at risk of aspiration, and he's dropping his GCS. So could you take over airway from Colin if you're happy, Pat, please?
Yes, that's right.
Mine has been placed.
Thanks, Colin. Alan, could you talk to Pieter? I think he needs to go for definitive hemorrhage control. Would you mind speaking with your consultant, please?
I agree, Karen. I think we need to go with Pieter. I'll get in touch with the consultant on call, and I do need to get in touch with gastroenterology as well.
Great. Can you let me know the outcome of that phone call, please, Alan? Thank you very much.
Do you want PPI?
No, thanks. Actually, there's no evidence for PPI in prior to endoscopy in these patients.
Okay.
How are we doing with the major transfusion protocol?
Yes, it's here. The pack has arrived, and I'm just about to give the fibrinogen.
So, John, I just want to give you some oxygen here and all different things, all right?
I wonder if you could prepare for a scientific blade for tube. Have you done one before, Colin?
No, I haven't.
Okay, well, would you mind taking over as team leader for the ORSI? And I'll prepare the scientific blade for tube.
Giving you some oxygen there now, John. So, John, are you going to do the checklist?
Yeah, we'll run the outside checklist.
Yeah.
So, do we have reliable IV access?
Yes.
Okay. 2 large bore IVs in the Have we optimized the position in fact?
Yeah, he's at 45 degrees.
That's brilliant. Airway assessment to identify the cruciform membrane.
Yeah, it's palpable, I can feel it here.
Okay, have we optimally pre-oxygenated him?
Yeah, I'm not pre-oxygenated while we're doing the checklist, then we'll do the bomb.
Let's optimize the patient state, so can we get a vasopressor, please? Epinephrine will do.
Okay.
He said he has no allergies. So prepare the equipment on the monitor. I can see heart rate, stats, blood pressure, is there any vital signs?
Yeah, I'm just taking inside the CO2 now.
Okay.
We're going to be active inside the CO2 now.
Okay. And in terms of the equipment, we've got 2 tubes with the cup check.
Yeah, we do.
We've got a McGraw and a direct rheumatoid backup. Bougie.
Yeah.
Suction is working and on.
Yes.
and we have the photoset in there in Friday. Yeah. So drugs, we're going to go with ketamine, rocuronium, 700 milligrams of ketamine, 200 micrograms of phenylephrine because the chemotherapy unstable. And maintenance sedation will go with propofol. It's a COVID time, so we'll do close intubation and no bagging. So the team roles, team leader is me, with RSI, first intubator. Yeah, I'll do first intubator. Karen is second intubator. Intubator assistant is Emma, and we have phone up. Karen, you have to perform phone up. Okay. Who do we call for help pack? We can call characters to theatre consultants. Super. Who's noting the time? I'll do that. And prepare for difficulty. So this is anticipated physiological and anatomy difficult. Can we wait the patient if it fails? No. Please verbalize your plan, Pat.
Well, the first plan is my plan endoscopy. I'll attempt twice. If there's no success, then can we attempt first time. If we've no success in that, then we move to plan B, which is the laundry mask airway. If that's unsuccessful, then we go back to that valve mask ventilation. And in failing that, Karen will do the 20 minutes.
Super, I'm happy with that plan. So, anyone have any questions or concerns? Okay, let's proceed. So, Colin, if we get 200 micrograms of phenylephrine, 100 milligrams of ketamine, 200 micrograms of phenylephrine given. Ketamine given, okay, and 100 milligrams of rocuronium. And the time starting now. 100 milligrams of rocuronium given. Okay, so quiet everyone, please. Okay, that's 45 seconds.
Okay, I'm doing the endoscopy now. There's a lot of soiling of the airway. I need to suck it out to get it on view. There's a lot of soil in there. I've got a grade 1 view there now. I'm bougie now. Passing the bougie now and through the dog again. I fold up at the groin. Okay, I'm advancing the tube. Just hold the bougie now and advancing the tube. Black mark is just above the port. Bougie out, please. Okay, let's make up the very mask. Inflate the cup before bagging.
Cups up.
Okay, I'm bagging now, checking for CO2. Can you listen for that sound, please?
Yes.
Okay. And we've got CO2 now on the monitor. We'll secure the tube.
Excellent.
This 24 centimeters.
That sounds bilateral and equal.
Okay, Ellen, how did you get on?
Okay, I'm ready. I chatted to my consultant on call and we're going to take this man to the tour and I'm going to go and talk to you and
okay, and are they ready now?
Yes.
And do they know he's hepatitis C positive?
Yeah,
okay, so we'll hold off on the same stick and like more trees then we're going directly to theatre. Emma, would you be able to hold the porters after you've prepared the equipment for transfer? Colin, I'll take back over as team leader. Okay. Okay, so let's summarize. Pat, you've secured the airway.
Airway secured on the
report is ventilating well, his oxygen saturation dropped to 95%. He's still tachycardic at 140 with a blood pressure of 80 on 60. And we've got 2 units of O negative running. The Pat 1 is here and he's had 2 grams of fibrinogen and he's got a radial arc line in. Is there anything else we need to do before transfer?
I don't think so.
Yeah, good idea. Keep them warm. Okay.
You need a catheter, I can put it off in
all right, Alan. Thanks very much for doing that. Okay, when everyone's happy, we'll transfer to theatre.
Okay, Mark, that was pretty intense stuff, but very true to life. Big GI bleeds are not uncommon. So once again, there was lots of really good human factors in this, just going down through a quick list, and then we can talk about the highlights. So we saw the handover from the pre-hospital crew to the resuscitation room, and that's particularly useful for colleagues who aren't often there at that portion of a patient's care to see the structure of that. The paramedics use a particular I suppose they follow the IMA-STAMBO mnemonic, but all the content is still there in a structured handover format. You can see the pre-hospital crew are identifying the leader of the resus to hand over to before they do so. And what's really well demonstrated is the complete silence and the pause in patient care that is happening when that handover is occurring. And that's really good practice. We then see the leader take over the resuscitation following the CABC approach. There's a lot of closed loop communication going on, and there's particular emphasis on PPE and safety because this patient poses an even higher risk because they're hepatitis C positive. I really love the way Karen named the various stages. So she names shock. She names that the airway is at risk. She names that definitive hemorrhage control is required, and that really helps the team focus on the priorities. Karen maintains situational awareness of all the elements that are going on, and that's hard. There's extensive phone calls going on in the corner. There's a lot of monitors beeping, and there's new team members arriving that she has to incorporate into the resuscitation, and yet she keeps the overview. The one time when she has to take over a technical task, which is getting the SenStack and Blakemore tube ready, she delegates that leadership role to a colleague, and that colleague then maintains the situational awareness. I thought Martin Bromley would be very proud of that RSI and that RSI checklist and all the verbalizing a task, etc. That was excellent. And there was also use of other checklists and aid memoirs, such as the major trauma protocol, etc. So there were some of my highlights. How about you?
Yeah, well, I have to agree with everything you've said. There were significant communication challenges with the PPE and the noise. They overcame them by speaking clearly and paying attention to one another. I agree with you about the importance of people verbalizing what they're doing so that everybody stays on the same page and everybody knows what's going on. And this is particularly important for the critical task of RSI that was being done. And we almost had a sterile cockpit situation there, which is really excellent. Everybody who didn't have to be doing something else at that point stopped, and everyone was engaged with what was happening, both with the checklist and in fact with the verbalization of how he was getting on as he intubated the patient, so that everybody knew where they were and what, you know, could plan if something went wrong. The other really good thing, I think, and very essential was when new team members arrived. The anaesthetist and the surgeon arrived for the first time. They needed to be brought up to speed very quickly, and it's really important when new team members arrive that the situation is shared with them and they can start forming the same mental model of what's happening as everybody else on the team has. They'd have been my highlights.
Yeah, I agree. I think because the leader, she set the scene very well. So even though there were multiple specialties came into the room, they all had the same, they were anticipating the same challenges, and they were all on the same page as the team leader. There was a good bit of collaborative decision making. The airway person was able to use those terms like, I am concerned, I am worried about the airway, and that was taken on board by the leader and then transferred on. So when the senior airway person arrived, the anaesthetist, she was able to say, I'm concerned about the airway, will you take that over, please? So I thought that was really good. And also the surgeon was involved in the decision making. There was a couple of options for this patient, depending on the particular resources of the hospital and that he was in. Some places might have gone IR routes, but the decision by the surgical team on this occasion was to go to theatre for upper GI endoscopy and banding. And there was a real collaborative sense of that happening with a lot of closed loop communication. So, I mean, I don't have any areas for improvement on that. I thought it was excellent. But, you know, when we come back to our the people involved in the simulation at the end of this, I'm sure that they may be, we're always more critical of ourselves. Perhaps they'll have some areas of improvement. Anything else you want to say about that, Mark, at the minute?
Yeah, I think they very clearly demonstrated the interplay between the non-technical skills and the technical skills. I mean, ultimately, you need good non-technical skills to ensure that the technical aspect of care will proceed smoothly, and that was very well demonstrated.
Great. And the team leader, there was lots of thank yous and making sure people was okay. Everybody was comfortable in what they were doing. And as you say, the leader was assertive, but there was absolutely no aggression there. So that was super.
It was an example of authoritative leadership, I think, would be the technical term.
Okay, you're the academic. That's the technical term. Thank you. So look, we're now going to move on to a piece of the resuscitation that we honestly don't do enough, and that's a structured hot debrief. And I can put hand on heart and say that this doesn't often occur in my department, so it's really nice to see this happening well, and this is led out by Vicky Megan. So Adina, would you be able to run the next piece, please?
Hi everyone, my name is Vicky Meehan. I'm one of the other consultants in emergency medicine on the floor today. That was a really complex and challenging case, so well done to all of you. I think it would be really good if we did a quick, hot clinical debrief on this using our stop debrief tool. So is everyone okay to stay for a few minutes for a debrief?
Yeah.
Okay. Great. Okay. So first of all, how are you all feeling after that?
Like, it was a really challenging case, but I think as a team we actually managed the resuscitation really well, so I'm happy with it.
Yep, sounds good.
Yeah, it was good teamwork and leadership.
Yeah, I thought it was good.
Yeah, I feel a bit tired and stressed out after that.
Yeah.
Sweaty but good.
Yeah. Okay, so the purpose of this debrief is so that we can review what's happened and we can learn together as a team about both things that went well, but also any areas that there are and opportunities for us to improve. So I'm going to start by summarising the case, and then we'll talk about the things that went well and any opportunities that we have to improve, okay? So this was a 55-year-old male standby call pre-alert, a patient who had a background history of decompensated liver disease and had hematemesis from esophageal varices. Initially, he was hemodynamically relatively stable, but he rapidly deteriorated and required resuscitation, activation of the massive transfusion protocol, emergency rapid sequence induction to secure his airway, and then transferred to theatre for esophageal banding and ligation. So to begin with, let's talk about the things that you feel went well. So what went well?
I suppose from a non-technical point of view, we had a pre-alert, which was nice because it gave us a chance to allocate roles and then to kind of mentally rehearse what we were going to do so that when the patient landed, we could kind of effectively and efficiently manage them.
Absolutely.
I think it was an excellent RSI and intubation, typical airway, and the team managed it really well.
Okay, good.
I think the teamwork was very good and the priorities were clear amongst us all, and I really liked the idea of the stickers with the names on and who we were. I think with PPE it's hard to know who people are, and that was a nice visual aid.
Absolutely, I completely agree with you that the stickers really help, particularly with the PPE that we have to wear at the moment.
Yeah, I defer to that as well. It removes any confusion of responsibility and makes the role allocation very clear. It's something we should do in ICU as well.
Yeah.
Like to take that from UB.
Fantastic.
Yeah, I think we worked really well as a team, and I think everyone was clear about their roles. Yeah.
I think Karen did a very good job leading us, and we had closed loop communication throughout.
So teamwork was really good and closed loop communication was really good, and your team leader managed to maintain situational awareness throughout by standing at the end of the bed. So all those things I thought were fantastic as well. Are there any opportunities to improve? Any things that you think could have gone better, or any areas for improvement?
I've never been taught how to do a snapsack and bagel shoot, so I'd love to learn that.
Okay.
I think it might have helped if there was a second resource nurse just to take the pressure off me because I was delegated a lot of roles. So it might have helped if I had a second resource nurse. And also if we had a rapid infuser rather than using the pressure bags, it might have got the patient might have received blood quicker and like helping the patient obviously resuscitate properly.
It would have warmed the blood as well.
Yeah.
Okay. Anything else?
I was able to activate the massive transfusion protocol, but I had a little bit of a delay getting to do the ultrasound.
Okay.
And from a surgical point of view, I couldn't get down when I wanted to be instructing theatres of laparotomy. It can happen sometimes that I'm scheduled in theatre and on call for ED as well. So that caused a delay on my behalf.
Okay. So I think we all agree that that was an excellent resuscitation, but we've identified a few areas that we could also work on to improve. So let's action those points. So Emma, would you be able to make sure that there are always 2 resus nurses available for a standby for resuscitation call?
Yeah, sure.
Forward? Is that okay? Excellent. Cal, we can do an ED training session on management of uproot GIBs, including how to insert a science taking Blakemore tube, and also run through the massive transfusion protocol and the details of when to incorporate an ultrasound into the clinical pathway. Would you be happy to lead out on that, Karen? Sure. Fantastic. I'll have a look into why our department doesn't have a rapid infuser available and whether or not I need to submit a business case to get one for the ED here. And Ellen, I will liaise with the clinical director for surgery to see whether or not with staffing allocations it would be possible to have a surgical registrar on call for the ED not scheduled for theatre. Okay. Okay, excellent. Thank you very much for your time, everybody. Taking the time to do this debrief, I think, is really important. Please make sure that you get a cup of tea and decompress after that. And Karen, do you mind giving the MRN of this patient to the Morbidity and Mortality Committee meeting people? Sure. So that we can discuss it in our Learning from Excellence segment? Right. Okay. Thank you very much, everybody. Thank you.
Okay, so there's the team, and that was an example of a really good debrief. So I say, just to say again, the most important message is that this doesn't happen enough. So it's great to see it done well. And as you can see, it wasn't done by the leader of the resuscitation. It was done by another senior member, in this case, another
I think Emily's
consultant in the emergency department. The stop pneumonia.
I think Emily's link might have frozen there. They used a technique called Stop 5 to do that quick debrief. The 5 stands for 5 minutes. You get it done within 5 minutes. So they summarized, they identified things that went well, opportunities for improvement, and points to action. And each team member had an opportunity to actually contribute. There are other reviewing tools, lots of them, to review situations. And some of you may have heard of OSCAR, for instance, which is an observational skill-based clinical assessment tool for resuscitation, or the team emergency assessment method, team. And for debriefing after simulation, you've got, for example, PEARLS, Promoting Excellence and Reflective Learning in Simulation. And there is some evidence that debriefs, apart from closing the loop on the event for all the team members, that it does lead to improved performance in the future. You back, Emily?
Yeah, I'm back, dropped out there. Okay, Fergal, do you have some questions from any of our audience?
Yeah, so we've a couple of questions. I suppose one obvious one is, debrief is great, but how do we incorporate, that's a question from Mike Barrett, how do we actually incorporate it into normal practice? Now, we also had a relatively silent background. Normally, the department kicks off and goes mad by the time that you finish the resuscitation, which is the very time you'd like to use the debrief. So are there ways that we can incorporate that into our normal practice?
I think I'll start if you like. I mean, I think it has to be given a level of importance. I mean, we're talking, the one we saw there is it's 5 minutes, or maybe even less than 5 minutes. So is it important? Do we feel it's an important enough thing to do to give 5 minutes at the end? And the only way it's going to be done, if you like, regularly, is if it starts being done regularly. I know that sounds a bit silly, but it's something people just have to do, I think. And I think it's valuable, and I think it's worth it. And I think if people start doing it, it'll I mean, what we didn't address there really is how you deal with the situation if things haven't gone well and you need to discuss things that haven't worked out so well. And doing it frequently will make that a lot easier, and creating a sense of psychological safety for staff to actually discuss things honestly without fear of backlash, and doing it on a regular basis, I think would be hugely beneficial.
Yeah, I would agree. I just think trying to push it up the list of priorities. I mean, I'm sitting here already thinking about a case yesterday evening that I haven't debriefed the team on. So hopefully when I leave this room, I'll go out and set up that debrief, even though I know it's too late, but we have to start somewhere.
Good. I suppose another question for Mark from Matthew McPartlin. How do you manage an influential individual whose knowledge of the CUS approach allows them to derail the situation in their own favor? Have you any thoughts on that?
Oh, wow. Okay. Well, you know, there are always going to be challenges, aren't there? But I mean, the important thing is to have a sense within the team that people can actually speak up if they want. But if someone is speaking up out of turn, part of the, you know, the flip side of that coin is that someone else can speak up and say, well, actually, you're speaking out of turn on this in this situation. Now, there may be you know, there are other techniques that can be used after the event. So, you know, you can go, and some of these situations mightn't be resolvable at the time. Ultimately, a team leader might have to take on a different type of leadership, coercive leadership, which is not ideal most of the time, but on occasion is required, and that might have to happen.
Okay, just a couple of last observations. Brian Flavin, I suppose, has made the point that the debrief can be done later. It doesn't have to be done immediately, and I think there are certain circumstances in which we would have all done that. And his other point, I suppose, it reflects the way that we were obliged to set up the video. So we were limited in the number of people we could allow in the room because this was done on RCSI and to meet COVID restrictions. But the question was really about transfusion, and do you not need further nurses for that? Now, we've taken, and many departments have taken, to having a nurse outside, often with a walkie-talkie, who can be involved, but from physically outside the room. So it is possible to get around some of that. But we have an obligation, I suppose, to keep the numbers to the absolute minimum for safety reasons, but at the same time, enough people to do the job. Okay, I think it, sorry, Emily.
A blood nurse.
Yeah, absolutely. Okay, yeah, and that person will often take the bloods that have been taken from a patient and make sure that they're processed and so on, and bring in stuff as and when required. But that requires another layer of communication from the resus room to a control room outside, which is a new dynamic and a new complication that we haven't experienced before. Okay, I think we'll move on to the pediatric simulation. If Adina could start that.
Okay, Claire. So we just got a pre-alert there. There's an 8-year-old boy, pedestrian versus car, multi-system trauma. So would you mind getting the trauma team ready?
I'll put trauma.
Thank you very much.
Okay, that's out, Sean, and I've let the ED consultant know as well.
Perfect. Thank you very much. Okay, so the story was an 8-year-old boy, pedestrian versus car. He's apparently got quite a serious head injury and some bruising along the abdomen. We'll get the full handover once the trauma team get here, just to save us going through things twice.
Okay.
Hi, I'm Sean. I'm Jess. Hi, Jess. How are you doing? I'm Sean.
Hi, Abby. Third.
Hi, Abby. I'm Sean.
Hi, I'm Deirdre, ED assistant.
Hi, Deirdre.
Linda, ED nurse.
Hi, Linda. Okay, folks, so the story is we've got an 8-year-old boy, pedestrian versus car. He's apparently received quite a serious head wound. There's bruising all along the left side of the abdomen. He was initially hemodynamically stable, heart rate of 40, BP 90 over 94 over 46, SATs of 94% on room air. So I'm just going to start assigning the roles.
He's actually traumatic cardiac arrest now, Sean.
Okay, so he's now traumatic cardiac arrest. Okay, well, we'll continue with assigning out the roles. So Deirdre, I'm going to ask you to do circulation. Doctor, have you ever done that before?
Well, today's actually my first day, yeah.
Okay, so so the priority is going to be trying to get access on this job. Okay, so if you can work on that as soon as you like. Yeah. Abby, you're a surgical representative, so will you look to see if there's any kind of signs of major external hemorrhage, let me know if there is. And then, and then proceed to your primary surgery. Jessica, you were the anaesthetic, right? You're happy to manage the child's airway?
Yeah, I have time to, yeah.
Yeah.
No, will you do circulation? Yeah, the start. And compression will take over.
Yeah.
I'll be her sleep.
Great. And everyone has their PPE on?
Yeah.
Wonderful. Does anyone have any further questions?
I don't know if you see it, if I an airway now.
Oh, sorry.
We're short today, Jen, but I can help you right now.
Yeah.
I'll do, yes. I'll be monitoring on, and if there's a more parents regarding it, I'll link in.
Perfect, thank you very much. Okay. So everyone has their roles, we're all familiar with each other, and no further questions about the management. Okay, great, we'll proceed into the recess room then, guys.
Oh, thank you.
Okay, so this is a bit of a heart sink scenario to start off, isn't it? That's a difficult pre-alert to take for the team. But we have once again demonstrated the usefulness of that pre-brief, that phase where you're just expecting a patient to come in. And you know, a tribute to our pre-hospital colleagues who really do try and give us that phase to prepare in the resus room. This is a non-consultant trauma lead, which is going to be the reality in the mass majority of our hospitals out of hours. So we can see the leader stepping into it, even though they're a bit less experienced. I really like the over the head labels for the trauma team members. That's a good idea for our own place. So we can see the trauma team lead taking the ASHISH information, assigning roles, assessing competencies, and asking about questions. I would probably a little bit of a safer way, rather than saying, you know, no one has any more questions, do they? You could say, what are the questions? And I suppose that would be really good human factors display. What did you think, Mark?
Yeah, it's good to, I think, reiterate all the basic principles, again, of the non-technical skills principles. A different scenario, different situation, different institution, different team, but you still bring the same basic principles into the room. And yes, I agree, all of the above, checked competencies, assigned roles, shared information, the established priorities, all of that was really good.
Yeah. So I think in the next video, we actually don't have the handover piece from the crew. So the next video starts with the resuscitation beginning. So Adina, could we see that, please?
Okay, team, so this is Bobby, 8-year-old, pedestrian versus car, significant head injuries, hip and abdominal injury, 20 minutes out, lost output, PA arrest initially, asystole on arrival here. So we're just going to take this from the top. We've got CPR ongoing, Linda, and everything is okay there?
Yeah, good CPR.
Jess, in terms of the airway, you're happy with the airway?
Yeah, check the position of the tube, I was ventilating, I have an S5.
Okay, so that's A and B are secured. So moving on to C then.
You just have a massive
We're going to need a line here to secure the line. What was that, Abby? Sorry?
There's a massive wound on his head.
Does it look bad?
Yeah.
Really bad head wound?
Yeah, that's true.
Okay, thank you for that. So yeah, if we can just get the line secured, because we're going to need to give you some adrenaline. Can't give anything without a line.
Oh, that's just terrible.
Really? Okay.
His head is really bad here.
Okay. Abby, you wouldn't be able to help with the line, or do you think you need to look at that head?
It's just his head.
The head is important. Okay, that's fine. That's fine. Okay. So we'll try and get that line in there if you can. I know it's not easy. Okay, Jessica, the airway is okay?
Yeah.
And we're still happy with the
CPR. Yeah, definitely need adrenaline though.
Okay, we can't get the adrenaline in without the line, unfortunately.
I'm doing my best.
Okay.
I can't.
That's fine. No, it's not easy. Here. I'm going to give you a hand here to try and see if we can get a line. Yeah, I see what you're saying. He's just very shut down, isn't he?
Well,
I will take a peek, but without the line, we can't really get anything done here. So, okay. Jesus, these visors.
Bobby, where is it?
Okay. We'll look at the head now in a minute. Okay.
It was reading for him, okay, and his heart actually pumping. So we have
Any look on your end, Deirdre, no?
ongoing.
Okay.
Okay, so I think the bigged issue there was obviously that the team leader, the relatively inexperienced team leader, lost situational awareness. So what happened? Well, he stepped in to take over a technical skill, which is fine, but nobody else was appointed to actually monitor the situation. There were a couple of interesting points there about what can happen. He was under stress caused by not being able to get the line in, and probably by the arrival of. Typically what happens in those situations is people get tunnel vision, they become fixated, and that's what happened there. The obvious clue is that the intraosseous was there. He didn't see it, and the person who was obviously had it in their head, thinking that it should be used, didn't speak up and say it to him. The team leader needs help as well. And sometimes even if someone says it once, it mightn't be enough. You need to get the person who's being assertive and saying, would you not put in an IO, needs to say it twice and make sure the person heard it. Because when they're fixated, they don't hear and they don't see. Vision becomes tunnel. It was really well done the way they portrayed that particular situation.
Wasn't it? And there was so much going on at that, between the situational awareness was even more important because we had the mum present, we had chest compressions actually going on, we had the massive head injury, which can be even a distraction when you're trying to just focus on the ABCs, and then the lack of parental access. So stepping back and keeping the situational awareness is really important. So I think in the next piece, we're going to see re-establishment of situational awareness. So could we see that, Adina, please?
Fair enough. Put pressure on his. This is Bobby. He's an 8-year-old boy. He was hit by a car. Got a significant head injury. Surgeons are very concerned about that. And then there's also some bruising along his abdomen and possibly a toe fracture as well. He was initially hemodynamically stable en route, lost output. The EA arrest initially transitioned into ASIS just before arrival in hospital. I think his downtime was 20 minutes before hospital, and he's been with us for about 3 minutes now at this stage. Airway is secured. CPR has been ongoing since he got here, but the big issue is we can't get a line, so we haven't really been able to do anything.
Okay, that's great, Sean. Thank you. Sinead, hold his moment. Sinead, I'll be with you in a second. My name is Laura. I'm supposed to talk to the team.
I'll try and that one down.
Okay, can I ask anybody who's not doing chest compressions or airway step back for a minute, please? Okay, my name is Laura. I'm the consultant covering. So we have our surgical reg, Abby, Deirdre, I know, Linda, I know, and our airway doctor is? Yes. Okay, so we're going to start from the top down, guys, and just do a quick refresher, okay? So from a C point of view, we've no catastrophic hemorrhage, and before we arrested, we were hemodynamically stable. Okay. Jess, airway-wise?
Yeah, he's in 18 student site, your effective position, a bilateral and able to ventilate.
And we've got end-type. Perfect. Our C-spine is immobilised. Breathing we had, we bilateral chest rise, and we're happy. And when was our last rhythm check with chest compressions?
We haven't done one.
Okay, and we have no access, is that correct? Okay, Deirdre, are you happy to put in a line?
Yeah, I've tried to put in a line.
Okay, have you ever put in an IO before?
Yeah.
Can I ask you to put in an IO, please?
Yeah.
Okay. And then disability-wise, so we have bruising to the chest and abdomen, Abby, but you were happy.
Yeah, that inside his head.
Okay, there's a large head.
I can help you get that.
Yeah, and that I always in there.
Oh, great.
Yeah.
Okay, so our airway is secure, breathing is fine, chest compressions are ongoing. We're going to do a rhythm check, Linda. If we just pause for a second. Okay, so we're asystole. We're going to give an adrenaline. Linda, can I ask you to give that?
What weight is he?
Weight 25 kilos is our estimate.
Okay, so 2.5 mils of adrenaline. Yep. Okay.
So Sean, I think our main injury is that head injury. It is quite significant. I'm going to ask you to continue. So rhythm check every 2 minutes and adrenaline every second round. Okay. I'm going to go and talk to Bobby's mom.
Our adrenaline is with him, guys.
Okay, guys. So.
So we can see there the consultant lead coming in, taking over the leadership role, reassessing the situation. I loved the piece where she asked to, other than CPR, can everybody stop and step back? And that gave that little bit of a pause to allow her summarize the situation. And Mark, I've heard you talk about getting everyone into the same mental model. So can you tell us, is that what she was doing?
Well, she was, as you said, she was re-establishing situational awareness and hopefully getting everyone back on the same page. There was a lot of good stuff there. There was closed loop communication. I think towards the end of that part, she was actually starting to signal a possible new mental model. So she was stating out loud about the severity of the head injury, the fact that it was the patient was in asystole, and that she was about to talk to the mother. I think starting to shift the mental model a little from what it had been, as in terms of saving the child, to maybe dealing with the futility possibly of the situation. Starting to signal that to the team.
Okay, and that helps the team all get into the same headspace at that stage.
Yeah.
Okay, so shall we move on and watch the outcome of this? Thanks, Adina. Yeah.
Hi Sinead, my name is Laura. I'm one of the consultants on. I just spoke to you there a few minutes ago. Okay. So Bobby had an accident this morning. I think you were there when it happened. Okay. Who else is at home, Sinead? Is there anyone else you'd like to come in at the moment, or anyone else you'd like to be here? Okay. So Sinead, as you saw when the paramedics arrived, Bobby was very seriously injured. Okay. And when the paramedics were there initially, his heart stopped beating. Okay. And they worked really, really hard and did everything they could on the way here to try and get Bobby's heart to restart again. But nothing they did worked. Okay. And since he's been here with us, my team and myself, we have done everything we could to try and make Bobby's heart start again. But Bobby's injuries are so serious, Sinead, that I don't think we'll be able to get his heart to start again. No. I'm really sorry, Sinead, but there's nothing more we can do for Bobby today. No. Bobby is going to die. I'm so sorry, Sinead. No. What I'm going to do is I'm going to go into my team now and we're going to stop the resuscitation because there's nothing more we can do for Bobby. Would you like to be with him? Yes. Okay. So Claire will take you in and you can stand beside Bobby and we will stop what we're doing and let you have some time with him, okay? I'm really, really sorry, Sinead. Okay. So guys, Bobby's mum is coming in. We're down now 40 minutes. We're still in asystolic cardiac arrest. He's a devastating head injury and I don't think there's any more we can do for Bobby at this time. I think we should stop resuscitation. Is everybody in agreement? Okay. We're going to stop chest compressions. Time of death is 12:01. And we'll step away and let Bobby's mum have some time with him. Thank you, everybody. So I think we'll take a few minutes and then we'll regroup down the tea room in a few minutes. Okay? Thank you.
Hi, Mark. So, not the outcome anyone wanted, but as I think you said already, you can see the lead has shifted people's, people's mental model to what the outcome of this is going to be. So we saw the lead involve the mother in what was going to happen to Bobby. But I think what was really important is that she wasn't asking the mother what should be done. Sometimes we're inclined to go into a relative's room, give the information and ask the relative, what do you want us to do? And that really is an unfair burden to place on families. So what Laura did there was she explained to the mother and she told the mother what was going to happen and what the inevitable outcome for Bobby was. And she tried to bring the mother along with her. And that was very hard in the face of the mum's resistance. You can see the mother there going, no, no, no. So Laura had to move from, she gave a warning shot about the severity of Bobby's injuries. She used language that Bobby's heart had stopped beating. And then she had to move on to that Bobby was going to die. And you can see how she staged up that breaking of bad news with Bobby. And then she offered the opportunity of witness resuscitation for his mother. And she prepared the team for that. That can be difficult on both the family and on the team members to have witnessed resuscitation. But I think you can see how that was done in a calm manner. What did you think?
Yeah, I mean, there's a whole new set of non-technical skills around speaking to relative on breaking bad news. And we saw some elements of that being displayed there. We see as well the decision-making process for a really experienced clinician, this recognition prime decision-making. She's seen these situations before. She knows what the outcome is going to be, that it's that continued resuscitation is futile, as sort of an example of recognition prime decision-making. She checked that the team was okay with it, but still directing herself. And very definitive about each stage, stating it as it was, being clear about what was happening, not shying away from using the words, all very important. And she then at the end signaled that to the team that there would be a debrief. Again.
Yeah. Okay, so that's it with the simulation. So Fergal, can we hand back to you?
Thank you. There's a couple of questions that arise from that have been put to me. The first from Basi Ndoma Agba is it ever okay for the team leader to intervene when the team has difficulties? I think we saw that in both the first scenario where Karen intervened, and we effectively saw it in the second scenario as well. I think what's key to it is that they hand over the team leadership for the period where they're not directly involved. In other words, that there's a clear handing the baton to somebody and then taking the baton back from that person, and that's communicated. I mean, there will be, I suppose the nature of a consultant is that they will often have more experience of a particular technical skill than some of the people that might be involved in the resuscitation, and they often have to bail somebody out. So that's acceptable. That's acceptable provided it's done properly. A second question, a more complex question. Obviously, family presence is incredibly important, but would teams not make a decision to stop resus together prior to the family presence and continue until family presence can be safely and comfortably accommodated? Important to have a designated member of staff with the family from start to finish. Now, I suppose it's worth stating first, before we get into the specifics of it, that for the purposes of the video, we had to create the impression of a relative's room that Laura and the mother and a nurse was in on the same video clip that the resuscitation was going on. So there was a suspension of belief there, because we hadn't got the opportunity to have two videos running separately. So there was two steps to that. I suppose on the general question, and Mark and Emily, I'll put this to you, on the general question of the decision to stop and the order of doing things and whether the family should be there or whether you should continue until the family arrive. What are your thoughts on that?
I would agree that it's better to have a sense of control before you bring the family in, and perhaps have a reasonable sense of of anticipating where this scenario is going to go. So I think having a reasonable grip, you don't always get the opportunity. Sometimes relatives arrive unexpectedly into a suspect situation, but that would be the time I would like to bring relatives in. How about you, Mark?
I think the important point is that there is signaling to the relatives about the way things are going. So it's not a complete sort of hitting a wall. And that can be done either in advance if they're not actually in the room to start with, or they can be taken aside by a staff. If, you know, hopefully you'd have a team member who'd be able to take them aside and just explain to them, even during the process, you know, what was happening, and give them some signaling as to what the outcome might be.
So Eva Doherty, who many of you will know from her RCSI Human Factors long years of teaching this particular vitally important element of care, has made the point that you know, this is a situation in which there really needs to be a debrief. I mean, the scenarios of pediatric death, those that talk and die, those that, shall we say, inexperienced people don't expect not to survive, they're particularly important. It's particularly important that a debrief takes place for them, and I think that would be helpful, because there will be lots of feelings of inadequacy around that resuscitation, not because of a failure to do something, although people may focus in on the failure to get IV access, but the key issue here is the futility of the resuscitation in the first place because somebody had an unsurvivable head injury. So thanks for that, and thanks for all the questions. We had about 125 participants in the session. I'm just going to close now with just a few last slides and thank yous. So I suppose firstly to thank all of those who have come to the session, albeit virtually. There were some technical issues with the videos which reflect the reality of trying to carry that out in a COVID era, but also the actual practical difficulties of PPE and the difficulties it causes with communication. I think although it may have made it difficult for people to hear all of the interactions, it does reflect the real world and real world quite accurately. Thanks to those who have asked questions. They've been helpful, and I think we've answered all the questions that have been put to us. The only other one was one from Suzanne Creed, who basically asked whether a human factors approach could or should be taken to the analysis of adverse effects. And I would be strongly in agreement with that suggestion. Is that it's not always that people do something wrong, it's just that the whole on occasions can be less than the sum of the parts, and therefore bad things can happen. I have a number of thank yous to make. Firstly, my emergency medicine colleagues, so Mark Doyle, Emily O'Connor, Karen Harris, Vicky Megan and her TALA team, Laura Meldy and her Crumlin team, and Jerry McCarthy from the EMP for a lot of the early work on this. The idea primarily came from Emily. Colleagues in RCSI, Adam Roach and Conor Dunphy did Trojan work on trying to make the videos as usable as possible, given the difficulties, the practical difficulties, and facilitating us often at short notice. Adina Orak, who's essentially run this with Pauline Lyons from the control room, and Claire Bryant from IEM. In terms of the two teams, Vicky's team composed of Karen Harris, who's consultant in emergency medicine in Sligo, two of our C-STEMs based in Tala, Callum Swift, who was the airway doctor, and Colin Bryan, who was the circulation doctor, Owen Connolly, the advanced paramedic supervisor based in Tala, Emma Byrne, the clinical facilitator who acted as the emergency department nurse, Ellen O'Byrne was the surgical trainee, and Pat Conroy was the consultant intensivist and anaesthetist who were part of the scenario. So a sincere thank you to each and every one of them. The Crumlin team was Laura Melzi, consultant in pediatric emergency medicine, Georgia Philbin, fellow in pediatric emergency medicine, Jess O'Connell, SPR in emergency medicine, Sean Cron, SPR in emergency medicine. And to be fair to them, they were asked to produce a scenario in which there were technical issues. So please don't cast aspersions on their competence because they couldn't notice an intraosseous needle was available. Claire Doyle was the clinical facilitator. Abby Healy was the emergency department nurse. Linda Farron was the resuscitation training officer, and Sinead Russell was community liaison nurse. So a sincere thank you to each and every one of them, and a sincere thank you to all of those who joined the session, which I'm now going to bring to a close. So thank you very much and enjoy the rest of the conference. Thank you.